Hello, everyone, and welcome to Women's Health with the Listening Midwife. I'm Day Day, aka the Listening Midwife, and today I've got with me, oh my gosh, pause for dramatic effect, Dr. Jessica Fletcher. She's amazing. So she is a consultant psychiatrist. So today we are going to be talking about perinatal mental health for women in general, but obviously, as you know, I'm a midwife, so we're always going to bring that back to, how we can support women across our fields. So without further ado, shall we get to it?
Let's do it.
Amazing. So Jessica, why don't you just introduce yourself to our listeners, because I have not done you justice by just calling you just a consultant psychiatrist. So tell me a little bit more about yourself. How did you get into the role? What is it that you do? How do you support your patients?
Yeah, cool. Thank you for that introduction. I was really enjoying the flattery before, so thank you so much. So my name is Jessica. I am a consultant. I'm a general adult consultant psychiatrist with a special interest in perinatal psychiatry and forensic psychiatry, and also ADHD and psychosexual therapy. So just trying to mush all of that in there. But my main interests are perinatal psychiatry and forensics. So yeah,
amazing. Wow, I don't even know what half of those things mean. I heard perinatal and I was like, I know that one.
I don't know. That's me. Yeah.
Exactly. So it's just amazing to have you here and to just talk with you. Like, we've done no prep, no background, so this is all going to be like a great learning for me. So that's how I roll. So we know that currently, like, mental health in the UK is like a big challenge. Like, we're seeing more and more cases. So tell us a bit about your experience in the field. How long have you been practicing, and what do you commonly see in your practice?
Yeah, so I kind of stumbled into psychiatry in medical school. So before medical school, I was adamant I was going to be a forensic pathologist. I was like, CSI, that's me. I'm going to do that. That's what I'm going to do.
We all dabbled with that thought, I think, for back in the day from CSI. So
I was determined. Everyone knew that's what I was going to do. I even did like summer schools in forensic science. I was serious. I was like, I was like, this is me. It's CSI. I'm there. That's me. And so when I was in medical school, in second year we had an option to do what are they called? Special study modules, SSM. Yeah, special study modules, and you could kind of pick like a module that you wanted to do. Yeah. Other than the things that modules that you had to do, and there was one in forensic psychiatry, and obviously I was like, forensics.
Okay, close enough.
Yeah, exactly. Yeah, I didn't know what it is. I just saw forensics. I was like, I'm down. And then I did this module, and it was in so there's I don't know how well known, but in mental health is well known. But there's a well known hospital called the Royal Bethlehem, in Beckenham, and there is a forensic unit. So that's where the SSM, the special study module, was. Yeah, and that was my first introduction to psychiatry, and I was like, oh, this is cool. Yeah. So throughout the rest of medical school, everyone knew I was going to be a forensic psychiatrist. I was like, that's it. Yeah, I found it. This is we can leave the the CSI. I can kind of I found what I was going to do, and then that was kind of my introduction to psychiatry. And then when I did my foundation training, one of my jobs was obs and gynae, and I loved it. And I thought, oh my gosh, am I not going to be a psychiatrist?
Yeah,
because
you're like, how are we going to put these two things that I love together?
Yeah. And then I'd moved on to another job, and there was it was maternal health week, and one of the speakers was someone who'd experienced postpartum psychosis, so she was an expert by experience, and that was my first introduction to perinatal psychiatry, and I was like, there it is.
Perfect timing.
Exactly. Again. So from then I was kind of like, okay, I'm going to be a perinatal psychiatrist. So I started psychiatry training in 2017. No, 2017? Yes, 2017. Training in 2017. I actually worked for a year as a locum kind of agency before that, just to make sure I wanted to do psychiatry, because I did a psychiatry job. I did my foundation training in Jersey, and Jersey's lovely, but it's not real. Do you know what I mean? No offense to like the Jersey
Shore.
It's just like it's just really
it's like
lovely.
Its own ecosystem.
Yeah, exactly.
It's just a little bubble of wonderfulness.
It's wonderful.
Yeah.
I just make sure I actually want to do this.
Yeah,
like,
and then you came to London.
We were like, exactly. I came to South London. I said, if I would do psychiatry in South London, I can do it anywhere. I can do it anywhere. I can do it anywhere. So I literally worked in South London in mental health for a year, and I was like, okay, fine, yeah, I'll do it. And then I started my psychiatry training in 2017, and I became a consultant in 2023. So
wow,
yeah.
What a journey! Amazing.
So, yeah, that's where I'm at. Yeah.
Fab. So tell us a little bit about what you see commonly in like your day-to-day practice.
So I'm in a very unique position at the moment where I'm actually able to do a little bit of different parts of psychiatry that I'm interested in. So I work in an ADHD clinic, kind of like a private clinic, and I also work in a prison, and I also work in perinatal at the moment. So I'm kind of doing the kind of ADHD neurodiversity and the forensics with the prison and perinatal with perinatal. So what I see is sort of different depending on what day of the week it is.
Yeah, exactly. Wow. That's quite nice. Varied job.
Exactly.
So you don't get the same thing day in, day out.
Precisely. Yeah, I'm never bored. There's never a dull moment.
That sounds amazing.
Yeah.
So just for our listeners who may not really understand, what is psychiatry?
Yeah. So psychiatry is essentially the medical practice of mental health. So people often confuse psychiatry and psychology. So psychology is sort of like the science or the study of the mind, but psychiatry is, like I said, the medical side of things. So you go to medical school, and mental health is one of the specialties that you can choose. So like obs and gynae, obstetrics and gynecology, or cardiology, or gastroenterology. Mind, brain. Well, the brain's more neurology, but the mind is kind of like the field of the medical side of medicine. So that's what psychiatry is.
Amazing. Okay, so you said like one of your many roles, or one of the way your roles is divided is that you do a bit of perinatal mental health. So tell us a little bit more about that.
Yeah, so that's a real passion of mine. I absolutely love my team, and I'm sadly going to be leaving soon because it was maternity leave cover, which is ironic because it's perinatal. So perinatal psychiatry essentially is the mental health, like looking after the mental health of women surrounding pregnancy, so kind of peri. So during pregnancy and a year or 2 years postnatally, depending on what part of the country you are. So with some teams, it goes up to a year. Other teams, it goes up to 2 years. So kind of like looking after the mental health of women surrounding that time, because as of course it's it can be a challenging time, as wonderful of a time it is. It can be a time where a lot of changes happen in the body and in the mind, and so so that's what
I think mental health is a huge part of everything that we do in our day-to-day as women anyway, but like in the most uncomplicated, straightforward, easy as it were, pregnancy is still very challenging.
Exactly,
So actually, like if you have, a predisposition to mental health conditions, or if you're already suffering from mental health conditions, and then you add pregnancy, the hormonal changes, the physical changes, the emotional changes, the relationship changes as well. It's a battlefield.
It really is. It really is. It absolutely is.
It's just this crockpot waiting to like kind of explode.
Exactly.
So okay. So and what does your day-to-day look like? Like in terms, I know you said you sort of look after women during the pregnancy, perhaps, and then up to a year or two after they deliver. Like, what do you come across on your day to day?
Yeah, that's a really good question. So it varies and it doesn't. So because it's perinatal, we know that we're working with women.
Pregnant.
You're pregnant. Yeah, exactly. Pregnant or baby. We know there's kind of one or the other. Sometimes both. Because some people are like, oh no, I'm not gonna have another baby. I said, are you using contraception? Because exactly, you guys know
I'll be out of
exactly.
a job if everyone who said it
literally.
So we don't believe it.
We don't believe it at all. I don't believe it. I shouldn't believe it. I don't believe it either. But sometimes they've got a baby and they're pregnant as well. So it's kind of again managing that, because being pregnant is one thing. If there's a mental health difficulty, being pregnant and having a newborn, or not maybe a newborn, but like having another baby is quite difficult. A young child, so it can be quite difficult. So I guess maybe I can talk through the structure of my day. So typically I'll have a clinic in the morning/afternoon, and there will be either new referrals or follow-up. So referrals can come from anyone really. People can even self-refer.
Okay.
Yeah, which is really good.
Yeah.
So self-referral, midwives, GP, literally anyone. Anyone can refer to the mental health to the perinatal mental health team. And that sometimes is for women who already have a diagnosis. So they know that, they already had depression when they were pregnant before, or they have an existing diagnosis of depression now, or anxiety or anything. But sometimes people will develop difficulties during the pregnancy or even postpartum. So, completely fine. And then, a depressive episode or anxiety or OCD or rarely like a postpartum psychosis. So you mums are heroes, because you can literally lose your mind. You can, like, quite literally, like, you can actually.
It feels like that regularly.
I can imagine. I can absolutely imagine.
It does feel like
I can imagine. But it varies. But on the day-to-day in my clinics, it tends to be depression, anxiety, OCD, managing medications, making referrals to other services, psychology services. In our team, we're quite fortunate because we have nursery nurses, we have peer support workers, we've got a specialist midwife. We can kind of make referrals as needed, and then also sometimes social services and things like that. So it can vary, but sometimes you do have the incidents of someone becoming psychotic, and you have to see them in A&E and kind of do the necessary thing. But on whole, it's usually kind of depression, anxiety, OCD. Those are the main things that we see.
So just to kind of talk a little bit more about that. So what happens is at your booking appointment, you will be asked a load of questions, lots and lots of questions. And part of that process is trying to ascertain what support you need during your pregnancy. So the midwife will go through questions about your previous pregnancy, your physical, medical health, all of that history. And also then she'll ask about your mental health and well-being. And for some women, they'll be absolutely fine, no concerns, or they'll be newly pregnant, and actually that unearths quite a lot. In case, if they've had previous trauma, sometimes these things can surface when you are newly pregnant and then trying to navigate that journey through pregnancy. So that's when the midwife will then offer you referral to perinatal specialist services. So usually the hospital will have perinatal mental health midwives who can then triage your referral and say, actually, we think that we need to link in with perinatal psychologist, perinatal psychiatrist. We need to link in with either local community services and sometimes social services. And that's not necessarily with the view to take your babies away. So please always do bear that in mind, that they are a service to offer support.
Absolutely.
Their primary focus is to ensure the safety and well-being of yourself and your children. And that can be in ways to provide you with more support in your home environment, not necessarily to remove children. Obviously, in worst case situations, not always related to mental health, it could be related to other kind of issues, that's when social services will talk about removal. But generally, that is the furthest thing from their minds at the point of, offering support. So it could be that actually you need peer supporters who might be able to help you, and getting your other children to school, for example. Sometimes if you're pregnant and you're going through a lot emotionally, mentally, then even just getting up to get your kids up to get to them to school on time, sometimes you might have challenges with that. And actually then, there's a lot of services that can then put things in place to help you with that process, not just about removing your children.
That's very true. I think that's really important.
It's really important to talk about that, because I think we get a lot of people are like, I don't want to talk about my mental health because I'm worried about social services coming in and being involved in removing my children from me, or making me feel like I'm an inadequate parent. We all need help sometimes.
Absolutely.
And there's no shame in
none whatsoever. None whatsoever. Especially when the help is there available.
There's so much help.
Exactly.
We are a really privileged country, because there's a lot of even though we know the state of the NHS, and we know that where we would desire there are more services, but actually in this country, in this Western world, we are very privileged to have a lot of support for women. And the stigma, we're starting to break that down as well, so that at least as a service we are not we're trying to break down those barriers so that there's less stigma involved for women.
Absolutely.
I love that. The next thing I just want to talk about is a few facts about mental health women in the UK. And then we'll ask our expert for her opinion. So in the UK, women are more likely to experience common mental health problems than men, with approximately 1 in 5 women affected, particularly by anxiety and depression. Young women aged between 16 and 24 are at the highest risk, and over a quarter are currently reporting mental health issues. So this is a really big challenge in the UK. And some of those key drivers that do impact the rates include trauma, abuse, poverty. So we know that the cost of living is ridiculous at the moment. And so all of these kind of things are driving us into that poverty line, and that's making it harder for families and for women who are trying to tend to those families to actually, you know, meet the requirements of that. And then caring responsibilities as well. So if you've got your young children, if you've got relatives who are elderly or sick, and now we know that, you know, our older people are living longer and there's less resources available. So we find that actually as matriarchs, most women are having those caring responsibilities as well. So there's a lot of changes to life and society, and that's having a huge impact on women. And then we go into kind of the health disparities as well, where we think about the impact on women of colour as well. There's a huge disparity in terms of outcomes for and even identifying some of those risks for women of colour. So with all of that being said, what are some of the challenges that you notice when supporting women in their families?
I think one of the I'll start with the positives, and then I'll kind of, because I don't want to seem like we're bashing services or I think one of the positives is that there's a lot more awareness regarding mental health, which is fantastic. There's still stigma, of course, which, you know, but compared to years ago, I think that we're kind of, like you said, working towards breaking that stigma surrounding mental health, surrounding needing help. Sometimes it might not even just be mental health, like you said, it might just be needing help. So that is positive. But having said that, the stigma is still there. There are still communities where asking for help is almost frowned upon or not encouraged. Even if it's not frowned upon, it's not encouraged.
It's just like the thing we don't talk about.
Exactly.
Like
you just do it. Just go on with it. Exactly.
Like it's just that, you know, it'll pass. And
it'll just pass. We've all done it.
We've all done it. Like we've all been there. Stop being so
dramatic. Exactly. And it's really not helpful.
It's really not
It's really not, do you know what I mean? Like it was different when you did it.
Everything has changed.
Everything has changed. So that there are unfortunately a lot of communities where that is still the message that these women are hearing, and it's really not helpful. And it means that, so for example, I work in East London, and the area that I work in is predominantly South Asian. So most of the women that I see are South Asian, which is fair enough, because that's where they are. Yeah, exactly. But there's also a quite large community of Black women, but they're not represented. And now maybe they're fine. Maybe they don't need perinatal mental health services. But I wonder if maybe if that is reality, and I wonder if actually it is this, like, you know, mums and aunties and all these other people are kind of like, oh no, it's fine. You just have the baby. You know what I mean? Like, you're gonna feel a bit sad, and then you're gonna be all right. Just go on with it. You know what I mean? This kind of like strong black woman trope that is it's really, really damaging. So I think that is definitely a challenge. And I think also what we've mentioned as well with social services or people's perceptions, that they think that if they're going to come to see perinatal mental health services or mental health services in general, that means that they can't look after their baby, and that social services are going to take away their baby. And I keep telling them, listen, I mean, I don't know if I should say this, but I'm like, there's no money for them to take your baby away.
They ain't got no money.
Do you know what I mean? Like they will literally support you as much as you can, because it's easier. Again, I'm not saying this is the reason, but you know, it's better for them to support you to look after the child rather than to just take them away. So
it's very costly to
try and take a baby
away. And actually, you know, like they
it's not done lightly.
It really is such a big decision that involves so
exactly.
many other services and so many multidisciplinary meetings.
Precisely.
Have we exhausted every other opportunity, every other option?
Exactly.
Otherwise,
exactly. And the aim is to make sure that you're safe and your baby is safe. You know, so that's. But again, people don't have. We don't get the opportunity to tell people these things because they're like, "No, I'm not coming," because like, you're gonna refer me to social services.
It's like, even just trying to open up that conversation and open up those opportunities to have those discussions then. To encourage women to come forward. So those are some of the barriers that we encounter in healthcare, in at least in maternity. We do have that challenge where it's like, okay, are we representing that community
exactly,
or do we, what work can we do to actually sort of infiltrate, as it were, to try and get that information
in there, so like, there is help there honestly is help available. We're not going to take away your baby, and actually we're trying to avoid that, because sometimes it does get to the point where children are removed, but that's when things are so bad that there are safety issues. And if we can avoid that, then let's do that.
And that proactivity helps us to avoid that, because actually what they'll look at is your family network, support systems that they can put in place for you with relatives and all of that. And that usually can avoid removal. Or
your mental health getting so bad that it has to get to that point, or the situation getting so bad. If you prevention is better than cure. So if we can get in as soon as early and as soon as possible, I think that's really important. And as you've mentioned as well, I think unfortunately these communities of women are also more likely, like you said, to be in poverty or to have these other struggles. And so again, those are the challenges. Sometimes people can't afford to come to the appointment because they're like, well, like I literally can't afford it. I don't have money. I really don't have money for this. I don't have time for this. So again, it's trying to work with these women. Okay, let's do a video appointment. Okay, let's do a telephone appointment. Let's do as much as we can to support you, so that you're not in this situation
what charities
alone.
are available,
that food banks,
and helping to support women, because it's all well and good. What I find commonly is like, oh yeah, you have the right to request time off from your employers to do, and that doesn't always, that's just not an easy solution for a lot of women. That there are things that can combat that. I think it's Maternity Action is a really great website if you are struggling with your employers. You absolutely can go to that website, and there's lots of information about how to manage that. And if you are accessing services, then as a healthcare service, there are things we can do. We can write letters as well to your employer to say, actually, you need the extra support in pregnancy. They need to make reasonable adjustments to support you during your pregnancy to ensure the best outcome for you and your baby. So that we need you to engage in order to be able to give you those services and tell you the resources and signpost you to the right places to support you. Brilliant. So I'm quite interested in a little bit of what you're doing with ADHD and neurodiversity, because that is something that we're seeing a lot more of, and we are encountering that in maternity services now as well. And I know that there's a little bit more money hopefully going into those kind of specialist services. We have that a specialist midwife in our trust who works a handful of hours to try and support women with neurodiversity, like admittedly diagnosed conditions, which is a huge issue, isn't it? Again, when we talk about mental health and neurodiversity and things like that, is that there is the diagnosis and the pathway to diagnosis can be quite challenging and very long.
Very long indeed.
But actually there's in between that is women who probably know they're neurodivergent or have a mental health condition but are not diagnosed yet. What can we be doing about that?
It's so challenging.
How do we fix it? Fix it.
Right, so what we're gonna do is I think, again, people being aware of their rights. So it's just think about ADHD, for example. A lot of people don't. I mean, the waiting list in a lot of areas, like some places up to 10 years, 8 years, exactly. So
insane.
Actually, it's so difficult. So one thing in that pathway is the right to choose, for example.
Yes.
So a lot of people don't know about the right to choose. So you have essentially the right to choose where you have your care. So with ADHD, as an example, and I think it's with a lot of other areas in terms of your health. But I'll just speak of ADHD because I know about that. You essentially can find organizations or services where you can have your diagnosis or assessment done sooner rather than like waiting 10 years. So
it's just wild.
It's actually right.
Yeah, it's wild. Right to choose, guys. Definitely
right to choose.
Look into that if you don't know about it.
Just Google right to choose ADHD and there's like loads of information on how to do that.
It's so good for everything. I think one of my colleagues had needed, was it toe surgery or something, and an assessment for that, and she just used that service. Incredible. And was able to fast track that process rather than just being told by a GP, this is the way and this is how long it's going to be. So for anything, even gynecology issues, if you're waiting to have endometriosis surgery or whatever it is, always check right to choose before you commit or say that that's the only thing that's going to happen.
Exactly. So just being aware of things like that, and then also just as as you're doing, spreading awareness about these difficulties, and also just clinicians being aware. So GPs, midwives, being aware of the services that are available, so that people can make referrals to these specialist services. Some services are okay, in that you can. I'm not saying get pregnant so you can be seen quicker, but if you are pregnant, then and you're struggling, you can be seen a lot quicker than otherwise, because we're aware of the I guess the risks involved involved with perinatal mental health difficulties. So there's a lot more kind of hands-on. It's a specialist service, and so in terms of mental health in general for women in pregnancy, that is one way that people can access services. Otherwise, contacting your GP and using things like right to choose. There are lots of charities as well. Mind charities is also
Mind
fantastic.
Is really
it's
good.
so
I'll pop
good.
a link as well.
It's fantastic. So kind of going through other avenues, but your GP is, I guess, the main way. The gateway. to mental health services in general. But when it comes to perinatal services, as I said, it's kind of where I work. I don't know how about other places. I think, but generally, you can kind of
midwife is really a good.
Exactly.
We're great for signposting because actually people know, right, I don't know this, but I know who does know it. And then we find the right pathway for you quickly. Brilliant. What I'd like to talk a little bit about, just briefly, is about medication. So a lot of women, so even if they've been brave enough and bold enough to kind of go, I need a bit of more support. I want to kind of engage with services, but I'm worried about taking medications in pregnancy. Like, what say you?
What say you? Sure.
Dr. Fletcher.
Thank you. That's really important. So one thing that I think is another part of the perinatal service is, I know I mentioned that the service is available. Available. We'll try
that again.
Let me try that again. My mouth said no. We're not available. Try that again. The service is not only. No, I think I said the service was available for women during pregnancy and also postnatally or postpartum. But actually, a lot of perinatal services offer preconception counselling. So that is preconception. So before
you get knocked up,
pre-knock up
before
service.
You are pregnant,
So before you're pregnant, and you can talk through your medications. You can talk through your mental health. Talk through what the risks might be. So, for example, if you have a diagnosis already of psychosis or bipolar, then the risk of of, you know, like a postpartum psychosis might be a bit higher, but we can talk about the ways in which we can manage that so that it's not, so that we can reduce the risk. So, you know, continuing your medication and what that means. So like, what can you continue this medication? Do we need to change to something else that is, you know, is better for baby?
For pregnancy,
and what I will say in terms of medication, we've got these medication, what are they called? Patient information leaflets, specific for pregnancy and breastfeeding.
Yes.
And at the bottom it says, babies do well when mums are well. And so I know that when it comes to medication, we definitely talk about the risks and benefit, because some medications are kind of like a no-no. And some medications were kind of like, well, the research shows that it's okay to take in pregnancy. There's a small risk of this and this and this. But let's weigh that up. Exactly.
Mitigate those risks.
Precisely. And you know, with the benefit is that your mental health is good, and that means that your baby will do better. So it's kind of like weighing up. So we're not like, oh my gosh, so stop all the medications, because oftentimes we're like, please don't do that.
Please don't do that. I mean, that is the first thing I'll say. With, like, having worked very closely with you know, mental health midwives and other support services within that, like, just don't stop your medication without having had a consultation with your team. There are medications that we would prefer to wean you off or change it around. And then there are medications that are absolutely fine to take in pregnancy. We might just be managing the dose, and we might be offering you extra scans for the baby just to kind of mitigate some of those risks. But don't stop your medication. There's a lot of medications that we use safely in pregnancy, based on your concern. So as Jess was saying, if you are bipolar, if you've got OCD, if you've got EUPD, any condition that's diagnosed, any condition that you're taking medication for, there's absolutely things that we can look at to make sure that you're on the right pathway and the right medication to keep you and your baby safe. Your mental health and well-being is vital to like your baby's health and well-being as well. So really important that we work collaboratively to support you in that period.
Definitely.
But I think that's the main thing I kind of wanted to get across is that medication is not a bad thing. It's not a dirty word. It's not, really not. Like, if you need to start medication in pregnancy, know that we absolutely will take your health and well-being and the health of the baby into account as well, and make sure that you're on the right medication that is safe to take. And one place I will direct women to is a website called Bumps. I'll pop a link down below.
I use it all the time.
I use it all the time. So I'm like, I don't know about that medication at all. Never heard of it. So Bumps is a really good sort of directory where a lot of medications, I won't say all, but like a very, very large amount of medications, like information about their impact on pregnancy and breastfeeding as well. So because women will say, oh, I don't know about this medication. I was taking it for X, Y, and Z, and now I'm pregnant. Do I need to stop? And I'm like, let's check together. Let's see. Let's see. So it's it's a validated resource that is very trusted by healthcare professionals. So go there and you'll get some information. Obviously, work with your team as well, because we know some things. I know some things. She knows more things about this than I do. So
but she also knows more things about things that she knows about.
This is why we're good company.
Exactly. On the topic of ADHD and medication, because I think that kind of links together. Oftentimes, well, for the majority of patients, we will say to discontinue ADHD medication. Again, kind of doing a collaborative with your team. Just don't stop any medication by yourself, basically, is what I say. But there are some medications, like ADHD medications, where typically they will be discontinued. However, if it's found that you absolutely cannot function without this medication, again, as they said, it's about monitoring and making sure that baby's okay, because if we stop the medication and you're not okay, baby's not going to be okay. So you said that, there are some medications, like with ADHD that we kind of say, if you absolutely don't need it, just we would say discontinue it or try something else, or but if you absolutely need it, we're not about just kind of completely stopping medications just because
just because of pregnancy. It's all about the balance.
Exactly. That's all we're trying to do.
Perfect. So I think we've sort of touched on preconception care, and I guess I want to go a layer deeper into that, just because it's so vital if you have a pre-existing condition as a woman and you're thinking about getting pregnant, that you access services quite early. So do you mind just telling us a little bit more about what that looks like? So you say women can refer themselves or go through the GP, like what can they expect from preconception care counselling?
So I think not a lot of people know about it. I don't know if that's the case, but we don't get as many as I think we should. And I think maybe it's because people don't know about it. But essentially, it's usually an appointment with a psychiatrist, and we go through your mental health history. So like a whole history taking, get to know about you, your medications, and then we have a conversation about what pregnancy might be like for you, given the medications you're on, given the diagnosis that you have, and what things are like with the team. So I usually will explain, because of the diagnosis and the medication, you're probably going to be under the care of a psychiatrist. So you'll probably see one every maybe 4 to 6 weeks or something like that, just to keep an eye on you. Exactly. But also, there are other members of the team that we might see where they might be needed. So like I mentioned, a nursery nurse, they say, after you have baby, they might be able to, or even before you have baby, actually, speak to you about how to manage things, how to look after baby, how to,
planning to breastfeed.
Exactly.
Nighttime feeds, or like,
precisely
what the structure they can put in place is so important, because actually it all goes out the window when it all goes out the window.
I can imagine.
Like that first 48 hours. And it's just wild. So just thinking about sleep deprivation.
Precisely. Yeah, exactly.
The impact of sleep deprivation.
Yeah, exactly.
On people who don't have a mental health diagnosis.
Exactly. I say it all the time. Like, the best of us. Like,
so then when you add a mental health condition, such as bipolar, such as even ADHD, even depression, anxiety, and then you've got this brand new baby that you've got to keep alive.
Yes, exactly.
While just clinging on to life yourself. With no sleep.
All of that.
How you birthed as well. So you might have had a couple of days in the run up to the labour and birth, or like the cesarean section, where your body is recovering from major abdominal surgery. There's not very much in terms of movement and things like that. Pain.
Yes.
Huge. So those are kind of huge triggers.
Absolutely.
For mental health conditions and the impact. So actually, preconception counselling is so vital to kind of go, right, so what are we going to put in place? Like, we know this is the standard medications that we normally offer to women for pain relief. What do we do if this is not enough for you? What else can we put in place to support you? So you're talking about nursery nurses as well. So they support, as we're saying, with like just general care of the baby, in terms of feeding, breastfeeding, because that in itself is a journey.
Yes, exactly.
If you ever had a baby, like latch onto your boob before, it's new. It takes some time. It takes some time. Just Dyson Hoover on your boobies. It's a lot.
Which are probably cracked and
even with perfect breastfeeding, you might still have some days, but especially if it's the first time you've done it. Like, your boobs have never been handled like that before. So it's all new sensations, which is what in like the emotional kind of impact of that. Some women may have a history of abuse, and that kind of sensation they need to work through whether or not that's right for them, and what that can trigger for them as well. So there's so much that preconception support and perinatal support can do in terms of working through all of those kind of feelings and potential issues that you might come across.
And what we can support with those things. So it's not just about kind of like, you might struggle with this, so
best of luck.
Let's how
so this is it. We identify it. And we put things in place.
Exactly.
And ultimately that might end up being medication.
Exactly.
But, there's loads of other things.
Exactly.
So we just kind of leave you to it.
Exactly. Okay, well, now you know. and sometimes it is, and it's a difficult thing to say. Sometimes it is maybe get things in place before you have a baby, which can feel a bit like, how can you tell me like when I should have a baby? But you're here for me to tell you that. So let me tell you, because if even practical things. If your housing isn't where it needs to be, or if you've, recently been in crisis, or we're still trying to figure out your medication, or you not keep in a negative way, but you have continuous mental health episodes, or difficulties. We might say, let's give your body and your mind some time to stabilize, and then you can kind of go into this journey of pregnancy and childbirth, because it's a journey. I mean, I've never been through it, but I've seen I've seen it, and I've seen enough. So sometimes the preconception advice is, with all of this in mind, our advice is to maybe just give it some time for things to stabilize, and then crack on.
Lovely. And so just looking at the other end of it, now you've got the baby, now you've got through the sleepless nights, maybe a little bit unscathed, maybe not, maybe a bit bruised, so you're 1 week, 2 weeks, you're discharged from the midwife, you may be under the perinatal mental health midwives for a prolonged stay, maybe 28 days, enhanced visits, and the team is so great. Like, I sit with the perinatal mental health midwives, and when you hear them just spending time on the phone with women, it's just a wonderful thing. I'm just in awe of them, because actually they just they relate with women in such a special way, and sometimes that's enough for some women to just go, can we do another check-in next week? Would you like to just talk things through again next week, and just tell me how you're doing, how baby's doing, all of that, and they do that during the pregnancy as well as afterwards. So if you've got use your perinatal mental health midwives. In most hospitals, most maternity units have that specialist service. It's a requirement as part of kind of the NHS plans that are in place, the long-term plan, saving babies' lives, like all of those things look at perinatal mental health and well-being, because we know the impact. So if you've got perinatal mental health midwives, make good use of them, and let them give you the time that they have to support you. Anyway, I digress. Back to postnatal. So postnatal support, that you wrap up with the midwife. What's the next step in terms of it's like perinatal psychiatry? You were saying that it could be up to 2 years. Like, what?
That? So before we get to postpartum, actually, so with some women, especially if they have what we call serious mental illnesses, so like schizophrenia, any kind of psychotic illness, bipolar, those kind of things. Or very severe personality difficulties, or severe. Basically, when it's a severe or serious mental illness, they will have what's called a pre-birth planning meeting. So we will have psychiatrist. They will usually have a named nurse, like a perinatal mental health nurse, and then the midwife, which will usually be the perinatal midwife, but also sometimes they have their own kind of midwife,
community midwife,
community midwives, and then anybody else who's involved in their care, so partners, if they want the family there, if there's social services involvement already, and it's a meeting to get everyone together, basically to talk about the birth. So we talk about what happens before, during, and after, like literally during, like like where you're going to be, how you're going to deliver the baby, if anything goes wrong, are you happy to, those kind of things. So we don't want to wait until you're like in the middle of labor, and then we're like maybe having a psychotic episode, and you're like, I don't want to have a C-section. They're like, but we need to have a C-section. So we want to
in there. It's a challenging place.
Avoid all of that. So
and also how long you're going to be in hospital.
Exactly.
For some women, it might be 12 hours, 24 hours, and then you'll go home. But actually, we know that the most crucial time for women is in that sort of first 48 to beyond that. I can't do the maths on that, but like 2 to 3 days. Especially because we know about that sleep deprivation and things like that. So actually, are you going to have a slightly prolonged inpatient stay where we try and get you a side room, maybe with an extra support nurse with you, or that kind of thing. So that's what that pre-birth planning meeting is about, and it's a great tool to get everyone on the same page.
Exactly.
Make sure you understand how the service is planning to support you, and what the expectation from everyone is.
Exactly. They're so good. I wish we could have them for everyone, but it's not possible. It's not possible. But it's really good, because then even practical things like do you have your bag packed? You know, we're gonna once we finish this meeting, we're gonna put it together as a plan. We're gonna give your midwife a copy. You're gonna have a copy. Make sure you've got your medication in a bag, so that when you get there, there's no, you know, things like that. That
simple
things.
things.
Don't
and
really
also
think
like
about.
even just like with the nursery nurse support as well. Like, where's baby going to sleep? So
exactly.
We just assume that everyone kind of has this thing, but actually, do you have the appropriate space? Is baby going to stay in the same room as you? Who's going to be supporting at night time with those night feeds?
Precisely.
So you can get a good night's sleep. Do you have that support in place? If not, what can we do?
Exactly. So, So we talk about all of that and kind of put it all together in a plan, and then so that support is already. I mean, they've already been seen throughout their pregnancy, depending on when they're referred. Because sometimes we don't, it's like but if we're seeing them, then at 32 weeks we kind of make that have that meeting, and then including that is what happens post birth. So, are you going to be reviewed are you going to stay on the ward until you're seen by one of the perinatal mental health nurses? Are you happy to do that? And sometimes you're like, oh yeah, fine. Like, but if you deliver on a Friday evening, we are going to be gone. So you have to wait till Monday. Are you happy to wait? You know, those kind of things. Some people are like, no, like, fair enough. But, we'll see if, the mental health team in the hospital will see you, those kind of things. And then the follow-up appointments, so the 4 to 6 weeks that I mentioned, that will kind of continue. If you have a nurse, they'll probably a perinatal nurse, they'll probably see you on a weekly basis or check in how you're doing, how things going, those kind of things. Within our service, I'm just kind of bigging up our service right now. Within our service, we have what's called an intensive pathway. So when we have these women, because we know that this I say 8 to 12, but I think the literature says 8 weeks. So the first 8 weeks postpartum for a lot of these women are the most high risk, are the highest risk periods. So we kind of, we don't do the intensive for like the whole 8 weeks, but like the first few weeks, they might be have someone checking on a daily basis, just to be like, hi, how it doesn't have to be like face to face. It can be video, it can be phone call, just to be like, you okay? You still okay? You sleeping?
And then it's like a gradual sort of step
exactly. It might be like once a week. Exactly. So a lot of women, like I mentioned, who have the serious mental illnesses or disorders, that will be part of the pre-birth plan. So we've got this intensive pathway. Are you happy for them to contact you? Some people are like, no, because daily is too much. I'm like, okay, fine, let's do exactly. I need to sleep. Every other day, those kind of things. So that's the support that's available immediately. And then, and then it's just kind of ongoing, the review. So even if you're 5 months postpartum, and at that point we're kind of like, oh, actually I'm struggling because maybe sleep regression or babies weaning. They'll be doing that. Or you're weaning, or also you need nurse support again, or you're struggling with something. So we've got the psychologist, or something
just changes,
life
happens,
life be happening, especially exactly, especially when exactly so the support continues essentially, and then once baby's 1, depending on where you are, the care would be transferred back to GP if they're kind of okay, or to general adult mental health services if they kind of still need support.
Okay, fantastic. Some final thoughts then. What would you what makes the most difference if we're looking at how healthcare professionals can support women who come into our services? Like, what would you advise? What would you recommend as sort of best practice for perinatal healthcare professionals?
I think from what I've seen, people are, other professionals are very much on it in terms of referring early. I think referring early is so vital. There's no, if you're unsure about a referral and you just make the referral, the worst they'll say is, oh, this is inappropriate, and then they'll just send it back to you. Close it, exactly. Like that's literally
nothing lost.
You literally nothing lost. So referring early is, wow, English is hard.
I'm keeping that one in. So referring early,
referring early is really, really important because we can avoid a lot of the difficulties that come about when people become very, very severely unwell, and we can kind of keep an eye on them. So, and I think just being aware of the services that are available.
Yes.
And also, as we mentioned before, I think sometimes you guys are sort of the gatekeepers or the gateway. So you can maybe explain these services to these women, like social services. Just like, they're not going to take away a baby. Like, they're not going to take away a baby. that's the main thing. Exactly. Yeah. They're not going to take away a baby. This is the support that is available.
Yeah.
Because sometimes women are like, what? Like, I've not seen a psychiatrist before. I've not really. So why do I need to see one now? Yeah. But just, it basically just explains it's a service that is available to women during this time, and just basically just take it because it's available. Yeah,
otherwise they'll take the funding away.
Exactly. Exactly.
Please use the
Please use it.
Yeah.
Please use it. Just being aware of what's available and signposting as you guys do. But just sort of doing that as early as possible.
Perfect. Yeah. And what would you say for family, those who are supporting women, like their partners, family, close others?
I think one thing that someone and I'm trying to figure out my words so I don't get like cancelled or like struck off. But someone will always look after the baby.
Yeah.
Like, do you know what I mean? Like, for the most part, obviously we know some people are, but someone will always look after the baby, but someone won't always look after mum. So even if it's just like asking mum if mum's okay. When you have a new baby, everyone wants to see the baby, everyone wants to cuddle the baby, everyone wants to, and this woman is like frazzled, her hair's all that, there's milk state. She's like, she hasn't slept in like 55 hours.
Her, man.
Feed her. Exactly. Like those practical things. Hold the baby so she can have a nap.
Let her have a nap.
Do you know what I mean? Like, do the washing up. Do those kind of things. And ask how she is, and actually like listen.
Yeah, listen.
How are you doing? Okay, thank you.
Cool.
You're like, baby. Like, no, like actually, how are you? How are you doing?
Giving space to talk and to be. That's so important because we live in a society where it's like, how are you? Fine. Yeah, I'm good. How are you? And we move on so quickly from that. But actually, what's really important is to give people space, especially in that really delicate transition where they're trying to figure out who they are now that they're a mum, who their baby is, because that changes almost on a daily basis.
Exactly.
So give them space, and give them an opportunity. So you're there to see the baby. Okay, see the baby too, see mum.
Yeah, you can do two things. You can cuddle the baby and just be like, exactly, and just be like, how are you doing? How are you feeling? And also don't be scared of the answer, because sometimes people are like, I don't want to ask because
I don't know what to do with it.
Exactly. She's gonna tell me stuff, and I'm like, but just be like, okay, well, I've heard that have you tried talking to your GP? Have you tried talking to your midwife? Have you tried talking to, do you know what I mean? Those kind of things. And because if you're not afraid, then they're not going to be afraid to share it. But if they're like, oh no, I'm gonna have to manage how I feel and manage how you feel about how I feel. Like, do you know what I mean? And there's this whole baby, and then
it's too much.
It's too much. Like, do you know what I mean?
I'm fine.
I'm fine. Exactly. That's exactly because it's like, I can't be bothered to deal with this. So be present for mums. Be present for mums, and also, so I guess the dad as well. I don't mean it in that way, but also them, because they're also trying to figure things out. And so, I think just practical things, and just actually asking, like, what do you actually need?
Yes.
What do you need? What do you need? I'm here for an hour. What do you want from me? What do you need from me? What would actually be helpful? Like, is it holding baby so you can eat? You can have a shower?
Yeah, like, hot food. Like, while it's actually
hot. Do you want to do that? Yeah. Those kind of things. And then like, if there are things that are concerning, don't be afraid. Sometimes if you can see that a mum is really struggling kind of beyond what I guess is what is expected, but if you're worried, you can contact services. So a lot of
on their behalf.
Exactly. A lot of you can contact the GP, if it's a crisis, you can contact crisis services on people's behalf, and just kind of raising the alarm early. That's the important thing. Just raising the alarm early.
Yeah, brilliant. Well, I think we'll leave it there.
Yeah,
that's beautiful. It has been amazing to have Dr. Jessica Fletcher. I can't stop saying it. We go way back. That's why I'm just she's a whole consultant. But yeah, it's been absolutely amazing to have her here. Thank you so much for taking the time to come.
Having me.
So please like and subscribe, share this content. If you know anyone who has a mental health diagnosis or struggles in general, as we all do from time to time, then do share it, especially if they are planning to have children, if they have children already and they may be wanting more, or they're just doing life like everyone, every one of us, So yeah, thank you so much. And this is Women's Health with the Listening Midwife. We'll see you next time.